So the online people weren't on before.
They were on before. I think we had over 40 people even watching. So there was, yeah. So,
Okay, so this
get
is a different
excited.
link now.
Yes, so I'm gonna post it on our socials and no problem. Hello. Yes. Oh, shame. Could I? Okay, let me ask Paki to assist you now. I'm just quickly sorting out some tech stuff. I'm speaking to. Okay, no problem. Let me ask Paki to get in touch with you now. All right. Sorry.
Hi everybody, I think we're going to go to the second session. Okay, folks, we are short on time, so I'm going to kick us off for the second session. But I hope that everybody's had a moment to catch their breath and grab a cup of tea. I think we left off with them, sharing with us some very sobering results and a lot to reflect on. And the second session reflects the multi-sectoral or stakeholder approach that we think is required to address this issue. This isn't just an issue for mothers or individuals who are experiencing this in healthcare facilities, but it's for all of us in civil society, government, etc. And what we wanted to do in the second section is to really give a broad sense of the response to these results, reflections, recommendations, and we're going to kick off with Dr. Leslie, or Prof. Leslie Bamford, my apologies. She's the Acting Chief Director for Child and Maternal Health at the National Department of Health. Leslie, I'll ask you to come up next. You have 10 minutes. I will be very strict with time with the speakers, so as soon as you see me raising up my white sheet, that means you've got about 2 minutes left.
So good morning, everyone, and thank you for this opportunity. So first of all, I think it's important to say it's not easy to stand here this morning. I think pretty much everyone I know, nurses and doctors, we went into healthcare believing it was a caring profession. And we pride ourselves for working in a caring profession. And so it really is very shocking to have findings like this put in front of us that really show just how little, not only how little care there is, but how much abuse there is within our health services. So I'm going to be very brief today. I want to make a statement and then I want to make 5 commitments. I'm someone who doesn't believe in making commitments that we don't know that we can achieve. So they may not be as sweeping and as broad as we would like them to be, but they are things that we know are doable. So first of all, I think it needs to be said unequivocally that obstetric violence in all its forms is unacceptable. And that is the position of us as the National Department of Health and all our provincial departments who are responsible for provision of maternity and other services across the country. So what are the commitments that we can make? So the first recommendation is about institutionalizing a respective maternity care. I was asked this morning, is this a new field for us, and the answer to that question is no, it's not new, it's not brand new, it's relatively new. So for the first time, our 2024 National Integrated Maternal and Perinatal Care Guidelines do specifically address the issue of respectful maternity care. The first 3 chapters of the guidelines speak to respectful maternity care, to maternal mental health, and to intimate partner and domestic violence. So we have guidelines in these areas, and I think most people would agree that those are good guidelines. So we can tick that box. However, we are painfully aware that those guidelines, whilst very good on paper, are not what is being implemented currently in our health facilities. So under this, I think we have 3 areas. So our commitment is to really push forward and to work with all stakeholders to implement the guidelines. 3 actions that I'm going to highlight. First of all, training of our healthcare workers. So in the Department of Health, we have the Knowledge Hub. We have online materials that healthcare workers and others can access. And we are committing that by the end of March, we will have the modules on these 3 areas uploaded onto the Knowledge Hub and available for healthcare workers to access. Of course, then we need to make sure that training is scaled up. And something that we will be looking at is how we can make training in respectful maternity care compulsory. We need to work with our people who train our healthcare workers, pre-service training, but also making sure that all our healthcare workers who are working in our services are trained on respectful maternity care and hear the stories that we have been hearing today. On the issue of birth companions, the guidelines include a woman's right to have a birth companion of choice with her. Again, we know there are some challenges with implementing that, particularly around infrastructure, where infrastructure is not conducive to having additional people in labor. But that is one area that we need to commit to figuring out how we can get around some of those practical problems. And then thirdly, the issue of informed consent. So in the last few years, we've done a lot of work around informed consent for sterilization, noting that women may not have fully understood particularly around sterilization. So we are much more confident now that no woman will be sterilized without her consent. Of course, there's still work to be done to make sure that that consent is fully informed. Okay, so let me move on in the interest of time. So that all falls under the first commitment, which is around implementing the guidelines on respectful maternity care. The second then speaks to strengthening our complaints and redress systems. So again, it's not that we've done nothing. We do have Mom Connect, and I hope that women do know about Mom Connect and do sign up to Mom Connect when they are pregnant. That is mostly a system for providing information to women, but it does also have the opportunity for women to leave compliments and complaints. Those complaints are followed up, but perhaps that is something that we can do a little bit more systematically and be a little bit more proactive about providing information about the number and the types of complaints that we are receiving. In our hospitals, we do have complaints procedures, usually falling under quality assurance. Again, I think there's a lot of work to be done to make sure that those complaint systems actually work for women, that women know about them and that they know how to use them. We do have an ombudsperson, and there are also legal routes that women can take. But I think the commitment is to looking at each of those avenues and thinking about how they can be made more accessible and more effective to women in terms of being able to complain and seek redress. The third commitment is then a need to have a conversation with our midwives and our nurses and all of our healthcare workers. I think we need to think about who needs to lead that conversation. We have a nursing chief directorate in the department. I think they have an important role to play. We also work with SOMSA, the Society of Midwives of South Africa, and we need to really think about what does that conversation need to look like. I think one of the most striking things is just how normalized abuse has become. At the same time, we need to give a voice to our midwives. We know that many of them are also traumatized. There's need for them to be supported. So we really need to put our heads together as the department, but also with everyone else to think about what does that conversation need to look like. The fourth commitment then, and again, I don't think it's for us to lead on this, but to participate in public education campaigns so that women better understand what their rights are and how they can, what the avenues, as I've already said, are if they feel that their rights have been violated. The fifth commitment is then to look at improved data collection and research. There are one or two of the findings that we actually are flummoxed by. We don't quite understand them. For example, some of the finding that almost a third of women said that had a Caesar without consent. So we really need to unpack that and understand what that means. So I think there is a need for more research, both from our side, understanding some of the findings, and maybe also going a little bit deeper into some of the findings, maybe also understanding how representative these findings are, although we really have no reason to believe that what is happening in Gauteng and KwaZulu-Natal is not what is happening in the rest of the country. A commitment also to improve monitoring. It's not easy to collect routine data on some of these issues, particularly in our facilities. But again, I think that is something that we need to really think about how can we strengthen our monitoring and make sure that any monitoring actually is used to inform decision making. So, for example, one source of data that we do have is, as I mentioned, Mom Connect. Our Mom Connect program manager is here. She does receive complaints, and that's a very low-hanging fruit where we need to be looking and analyzing and sharing those findings in a little bit more of a systematic way. So I'm not sure, I suspect I'm almost at the end of my 10 minutes. So thank you very much. Maybe just in summary, to just go through those 5 commitments again. The first being to implement the national guidelines with a particular emphasis on respectful maternity care, maternal mental health, and intimate partner and domestic violence. To strengthen our complaints and reporting mechanisms. To participate or initiate or participate in a conversation with our healthcare workers. Because, as has been said, we believe this can't be solved without our healthcare workers who provide care on a day-to-day basis, actually accepting and thinking about, accepting the findings and thinking about how to respond and how to create a more caring environment for women. We've talked about participating and supporting public education campaigns, and finally looking at improved data collection and research. So with that, I'll close. Thank you.
Thanks, Leslie. I think you were quite good with time. I'm going to call us our next speaker and just remind everybody in the room that we will have an option for Q&A at the end. So if you have any questions for specific speakers, please note them down now, and then at the end we'll direct those questions to them. But next up, I'd like to call up Ms. Winnie Muleko she's the Executive Director at the Health Standards Design, Analysis and Support Office of Health Standards and Compliance. That was a mouthful. Thank you.
Thanks very much. And thanks for the opportunity to come and listen to this report. I think it has come at an opportune moment because we are reviewing the current regulations that we are using to inspect our health establishment or health facilities. Now, the Office of Health Standard Compliance, it's a health regulator, and it was established when the citizens of South Africa, were telling about the poor healthcare that they were receiving from the health establishment. And I must also indicate that one of the issues that the users of our healthcare were complaining about was the attitude of our nurses. And I'm happy that at least one of the things that the health establishment have managed to do is to make their facilities clean. I was looking at, the percentage in terms of cleanliness, but it also doesn't say much if the very same facility is clean, but you are still being abused. Mm-hmm. So we need to make sure that we address, our problems in the health system. And I must also indicate that the Office of Health Standard Compliance, its vision is safe quality healthcare. And we are talking about the Office of Health Standards Compliance. When the presenter who was presenting the survey results was standing here, I was asking myself, where are the standards in this health establishment? Now, I must indicate that, and I've listened to Professor Leslie Bamford. National Department of Health is our principal report today. Now, in terms of these recommendations, they are going to be implemented. The reason being that when we set the standards, one, we look at the very same protocols, the guidelines, and the policies and ensure that the standard talks to that. And we go to the health establishment to monitor the implementation of the very same guidelines and protocols. Now, the challenge is when, these guidelines and protocols are set, are developed, but without looking at the skill mix, the environment where these things are supposed to be implemented. So we need to make sure that at the end, we are able to make sure that these guidelines are implemented. They are also talking about, equipment, availability of staff. And in our regulations, the current regulations that we are assessing, we are also looking at the consent form, whether the women who are accessing labor are allowed and told about a consent form and the procedure that is going to be performed. And we go through the clinical audits to ensure that the women have received safe care. But in most instances where the health establishments are not complying, we are also responsible because we are not holding those health establishments accountable. I think we need to start enforcing our, policies so that people are held accountable. That is the problem. I was listening to Prof. Bamford when she was talking about training. Training is good. We always say we will train people. Let's also create an organizational culture, a culture where the very same people, when they are trained, they go back and they are able to implement. There are functioning equipments. There is an environment where they can be able to do what they have been employed to do. And somebody has spoken about normalizing an abnormal situation. Those that are also overseeing this health establishment, they always have excuses. We must stop giving excuses to say they are behaving this way because they are overworked. The facilities are overcrowded. Let's go out there and make sure that we also educate our own recipient of these services to be able to complain. Professor Bamford has indicated there is health ombud. He's sitting next to my office, but he is responsible for those complaints that were not resolved in the health establishment. But people must also make sure that their voices are heard. And when you look at the patient experience of care surveys, the results are good. Because people will always say, anyway, I got what I wanted, even where they have been abused. Unless we are able to raise our voice and make sure that we are heard, then the abuse will stop. Those health establishments, they are our health establishments. One of the things that we are supposed to do in developing the standards, the principle is that we must engage with the communities that are going to be affected by the same standards. Now, we are at the level of engaging with all the stakeholders, provincial departments of health and the GPs. We are, by the way, started inspecting the GPs. They are not happy with us because we are looking at the environment. Some of them, they were just, providing these services, in the environment that is not acceptable. So one of the things that you are supposed to do is to engage with communities. And I am here, those that want to work with us, we will make sure that we address these issues that are here because our regulations are not prescriptive. They are targeting the problems in the health system. I have taken the reports I'm going to share with the CEO, I'm going to share with the health ombud, because it's like we have not even started stretching the surface. We cannot continue to say, establish this, establish that. Those platforms are there. Let's make sure that they work. Let's make sure that we strengthen them. If the health ombud needs to have offices in the provinces, then why is that? We can't establish another office. The office is there. we need to make sure that these guidelines that we always develop are monitored, are implemented, and we create an environment in our health establishment where the very same healthcare providers will be able to implement this. I am going to pause here and thank you very much.
Thanks, Ms. Melissa. It sounds like everybody's going to be very good with time, so I haven't had to raise my flag. I think it's very encouraging to hear the openness from government, the Department of Health around recognizing the challenges that exist and also understanding that there are platforms that exist. How do we close the loop? How do we have the conversations around accountability so that a year, 2 years from now, we're not reporting the same results?
Yeah.
We're going to continue with our lineup. I'm going to call up Dr. Kagiso Dukisi, who's the executive member at the Society of Midwives of South Africa. Thank you. Thank you.
Good day, everybody.
Hey.
I am a bit nervous because I am a midwife, so yeah, this is a lot. But I am here representing the Society of Midwives of South Africa, and as a society, we do acknowledge the report that we received this morning. A report that detailed the extent and nature of the obstetric violence as experienced by women who are, of course, our major clients. So this report provides insights into the care that we provide to those women, and it is, of course, an opportunity for us as midwifery society to reflect on our own practice as well as self-correct. So we do acknowledge that as midwives, we do have a critical role to play here. And if we are going to win with regards to the implementation of the respectful maternity care, we are the people to be guiding and driving this. The report did mention that 92% of the women who participated in this study suffered at the hands of the midwives. This proves the very fact that we are the primary caregivers. So if we are all going to win, we are supposed to be the people who are attended to. So respectful maternity care is already receiving attention in our society and in midwifery in general, because we are educating, we are conducting researches on this. And this is because by the virtue of us being midwives, then we do have a responsibility to provide the direct midwifery care, as I have said, and thus midwifery care should have or should be infused with a whole level of high dignity and respect for those who come to us for help. And if there is that respect and maintenance of that dignity, then by all means, respectful maternity care is going to be implemented. So we are also very hard on education because we want the midwives to assume their advocacy role. And their advocacy in this context would be to advocate for women, even against our very own colleagues who might be perpetuating this very violence. So we are also hard on it because we are intending for our midwives to be able to educate and train not only the junior midwives who are coming after them, but also the communities so that they are very well aware of the nature of the care that we provide to them. We are also very grateful that the report recognizes that there are a whole lot of challenges surrounding this. And the long-standing critical shortage of midwives has been elucidated a lot in the study. And so is the infrastructure that is not supportive of the very respectful maternity care. So we are also very delighted to learn that the Department of Health is already hard at work trying to address the issue of the infrastructure and the critical shortage. But also, as a society, we are already making noise regarding the critical shortage of midwives because at the moment, we are participating in a petition that has been raised by the International Confederation of Midwives, which advocates for 1 million more midwives. So I think we can all understand that this is going to require a concerted team effort. So respectful maternity care already forms part of our midwifery training. I am speaking now from a midwifery lecturer's perspective. We are doing this. Our people that we are training, they understand that they are supposed to be greeting the patients because of Batuville principles. They know that they need to identify themselves because of the patient right charter. They know that they need to obtain consent. However, there are a whole lot of challenges that make this very education that we provide not to be implemented, and we do acknowledge that. Maternity care guideline is part of our teaching and learning material. And that document is very rich when it comes to the issue of the respectful maternity care. On each and every page, it reminds you of identifying yourself, obtaining consent, providing the support. Again, this suggests that there is a critical problem with regards to implementation, and it could be due to the very challenges that have already been elucidated. But we will then require a policy for this respectful maternity care because it is well known to enable all of us to not only standardize the midwifery care, but to also enforce some accountability in instances where non-respectful maternity care was done. So education and research continues even on our side as a society, and even in the conference that we are going to hold towards the end of this year, we will be having respectful maternity care and obstetric violence as one of the key things within that conference. Thank you. So that we continue to empower our midwives with regards to this. Thank you very much.
Thanks, Dr. Kizi. Next up, I'm going to call Ms. Dimakato Sibopa, who is from the Democratic Nursing Organization of South Africa, and she currently serves as the Deputy General Secretary. Please welcome me.
Good morning.
Morning.
I think I should be the scared one to stand here after listening to that report. Shocking results. And we agree with everyone that says that women should be respected in health facilities, whether by nurses, doctors, or midwives, cleaners, securities. When any patient enters the health facility, we must give them the honor that they deserve. Having said that, we have spoken to this to say midwives are the majority rendering maternal care. And of course, there are systematic issues that impede midwives to get to render the quality care to women. We don't take away the fact that there are attitudes in healthcare facilities, particularly in the public healthcare. And every nurse or any midwife has got to take responsibility of their own attitude, irrespective of what is happening. But what we want to address today is this systematic issues. We had the Department of Health saying this is what we are committing to do, but I think they left critical things. The first thing it has to do with the number of midwives that SOMSA is referring to. In this country, we are left behind by 10 years to have specialized midwives. The numbers that are approved for training of these nurses, it's less. So it tells us going forward, we are going to have more struggles. What does that need? It needs us to lobby for increase of numbers of midwives that are going to be trained. And it's a concerted effort for all of us. It's not only an issue of SOMSA and TINOSA and Department of Health. It's all of us to see how do we increase numbers, because already in our system, midwives are the ones that are taking care of nurses. Secondly, the midwife-patient ratio. Colleagues, if we will continue in this manner, I can tell you we can raise our voice, we won't win this. In maternity settings, one midwife, I don't know, is equals to how many? How many women? The one is delivering, the one is in pain, there's someone at the door, and there are only 2 midwives on a shift. That is not acceptable at all. Because as far as our training taught us, the one midwife is the deliverer, the other one is the conductor. The assistant nurse is the assistant to clean and assist us with other things. But we are the professionals that should be rendering the service. The issue of resources constraints. It is not acceptable, colleagues, that you should be in a maternity ward and the woman wants to deliver, but there's no package to assist you to deliver that woman. Equipment. These are the things that causes problems, and we are saying they are influencing how midwives behave in the system. That's what we are saying as TINOSA. These hierarchical, punitive workplace cultures. We are not talking about it. For instance, in Gauteng, we are servicing women from different cultures. Others are from Mozambique, others are from Zimbabwe, others are from Botswana. Now, when this woman who is from Mozambique, who wants to bear down, wants to use squatting, and the protocol in the facility is saying lithotomy. You can't change that. You are often told you are not here to change the rules. You are here to implement. So these things are the things that we need to cut. We need to cut. We need to allow women to make decisions about how they want to. I take it, but we need to have adequate training on respective maternity care, including communication, colleagues. Because we don't know how to communicate to patients. We don't know. And I think it is not only a midwife, it's an issue of a system. From where I'm from, I was taught how I should be able to take out the procedure on how a woman needs to do it. But I was also taught that no, there are ethics. But we need to get into deeper details of ethics in healthcare settings. What do they mean to an ordinary patient? In conclusion, we will only do this if we work as a team from all sectors. And we want to say that we agree that as well, data findings and accountability systems needs to be implemented. And we agree with the recommendations that you are making. But we are saying as well that the healthcare system needs to take care of the carers. If you haven't experienced a stillborn, you will never know. You will never know. And if you are a midwife that has not seen a stillborn, you will never know the pain. So we need to support those that are in the system.
Yes.
They as well require the system. So a healthcare system that support their professionals and the patients will go a long way for us. Thank you very much.
Thank you. Thanks to those last few speakers. I think for contextualizing the realities that are on the ground, and I think laying out the complexity of just the challenge that lays before us. What we'd like to do next is show 2 more videos of the Push Comes to Shove documentary. I'm going to ask my colleague who put them up initially to just pull them up. They're from 2 individuals, Shayna Fife and Amy Lester. And they also build on the initial video that we shared again, and I think bring to life exactly what has been shared this morning from Bert's presentation and also the reflections from our speakers as well.
When you give birth, being alone is a scary thing. I thought I was going to die. I thought I was going to kill my baby. So my own experience with obstetric violence was for the birth of my 3rd baby. When I was due to give birth, I came to the hospital and I was there on time. I was told where I was going to be, and nobody knew that I was supposed to be there, which was my first red flag. Regardless, everything went fine. The surgeons were wonderful. My C-section was successful. And then when I was sent back to the room, they'd forgotten to give me any pain medication. I don't like to show my emotions, so I didn't scream necessarily because I didn't want to make a scene. But I was in a lot of pain. My husband asked him to give me my medication, nobody came. Eventually, someone came and gave me one of the pain injections that I was supposed to get as soon as I left the theater. So after breakfast, we were told that we need to get time, pack up our things, and once we finished eating, we needed to move to the lounge area. I was scared to ask anything about it because it did feel there was this atmosphere of, you're done now, move it along. You sort of feel like cattle or like part of an assembly line just being moved along. So you go with it and you sort of train. The reason I tell you it's ingrained, this obstetric violence is ingrained, is that you were trained to say, yes nurse, yes sister, and just do the things because the doctors will raise their voice at you, the nursing staff will raise their voice at you. I knew that I was in pain, but that was the least of my concern at the time. I knew that either I was going to lose my mind and be a danger to my child because I was there for psychiatric care as well as giving birth, or because it was cold, because the windows were broken, because she hadn't been checked by a doctor. I honestly believed she was going to die, or be sick or damaged permanently from the situation, because I know what care is supposed to be given to babies from my previous births, and she wasn't receiving that, and I was terrified. After that, I went to private care, took my baby to a doctor. I got my stitches removed from a doctor because I was too scared to go back, and I was very traumatized. And because the service is free, and a lot of the women that are there need it and don't have options, there are no alternatives, you just take it. Yes, it is a free service, but I believe that it could run smoother if people took the time to fix the process. I think it's so bad because the government or people who have money and power don't care about the poor. I think that they are out of touch with us. If you can't see what's happening at the government hospital, all you think is these people are getting free healthcare and I have to pay for it. Because you know what? Pregnancy is a big deal because it changes your whole life. And women are sort of just like treated as, that's something you must do. Just get it done with. So when you are healing from something as traumatic as giving birth, there should be specialized care. And it shouldn't matter if you're someone with money or someone who doesn't have money. Every single woman going through that is going through something. in things. And if you're going to give us something at the public hospital, just because it's free doesn't mean it has to be paid. I think training in how to deal with people, not just with diseases or whatever the person's coming to you with. Training in empathy. Because that's important. People skills is important. You're not just a high-flying person that makes a lot of money by healing people. You also need to deal with human beings. What motivates me to keep going is that I know that there will be one person whose life is better with the information I share. Women were like, oh my word, that I had a similar experience. That's abuse. Because sometimes abuse is so ingrained, we don't recognize it. And what keeps me going is that I'm showing people, I'm letting them recognize it in their own life. Sharing our birth stories is often the first step towards healing and mobilizing for change. Embrace is a social movement for mothers that advocates for the priorities of early motherhood and is committed to raising awareness about the scourge of obstetric violence. I think raising awareness is important because women can recognize when they're in danger. And I don't think we always know when we're in danger. Because I think we are told to be quiet a lot. From the moment we are conscious, people are telling us to not make a scene. Don't be loud. You're making things uncomfortable. Just do it quickly so that everybody else is happy. Raising awareness and making people know that it's okay to speak up about stuff. I think we're empowered to share because of highlighting, because of giving it a face.
And we have a second video by Amy Lester.
I was neglected and I was ignored and it was extremely traumatic. It's just such a bizarre combination of feeling so deeply present in my body and in control and also just so alone. The anger isn't so much in the OR. It was the space before, that waiting space where no one cared, which is the most triggering and the most upsetting. My first birth experience was when I was 22 and I had just finished my study, so I was no longer under my parents' medical aid. I didn't know the government system very well. It was quite an amazing experience and it was quite an easy pregnancy. With the twins from the beginning, I felt different in my body. I moved to a private practice at a hospital in Cape Town. We spoke about, doing more of like a gentle approach to the cesarean, and I kind of made peace with it to an extent. And then I actually got COVID and I got a UTI straight afterwards. The doctor who was seeing us wasn't available, so another doctor came to see me. He came in quite abruptly, right pants off. He didn't draw a curtain. The door was wide open. And then he said that I've been having too much sex. He had blamed me for my UTI. And then he asked me how blood pressure was, and he needed to check me for hemorrhoids. I told him that it was quite sore and painful there. And then he gently smacked my bum afterwards, and he just said, don't worry about it, we'll sort it out, we'll get you something for that. And then I got angry. Then I sent an email to my doctor. He said, of course, we'll sit down, we'll make sure that when you do go into labor, this doctor isn't there. It was very unexpected. My orders broke at 31 weeks. So it was almost 2 months before I was actually supposed to give birth. It was the nighttime, so there were no doctors available. They put the CTG on to monitor the contractions. That's all they kind of gave me for that evening. So they said to me that the doctor was on his way, the man who had a really bad experience with the UTI. Dean was amazing. He just basically told the nurses that they had to send another doctor, which they did. I don't think he was a bad doctor, but I think he wanted to understand the situation, so he asked me what had happened with the doctor. I couldn't quite understand why I was getting interrogated about something when really the main thing to worry about is the fact that I'm in labor. Then I waited until the morning to see a female doctor. She examined me, and I was still quite early on in my dilation, so nothing had progressed too much. By 4 p.m., I was very much in labor. So there was a new nurse that took over, and I said to her, look, this is getting more painful. My labor is definitely progressing. You're going to need to call a doctor. And they didn't. I pretty much stayed in that situation up until 20 minutes before I gave birth. The plan was not to give birth vaginally, but I did because my labor had progressed up until that point and I was completely alone. So the babies were both born. Atlas was born vaginally. Judah was born cesarean. I mean, trauma, it's not one of those things that really goes away. So you just kind of learn to live with it. I felt very detached from my body for about a year. It was hard for me to understand what was happening. I was feeling it. Neglect is a form of obstetric violence. As you bring life into this world, you should be feeling safe and protected and held with people that have a sensitivity towards what you're going through. Essentially, if we don't get better afterwards, it just becomes systematic trauma, which will affect our kids, their kids. We did send quite an excessive mail where we kind of explained the whole experience from our perspective and how we were very disappointed with how it happened and how we were essentially ignored, and we didn't get a response for over a month. The HPCSA actually did phone me. They were amazing. They did tell me that I needed to re-report the situation with the doctor that was super inappropriate with me, and I didn't. Mainly because I just didn't have the energy. Embrace is important because it has been a lifeline to women who are dealing with some really difficult things. It's making it easily accessible, and it's bringing people together who might feel alone.
I'm going to invite our next speaker up, Gefilwe Sibenya. She is the Executive Director at the Doulas of South Africa. She's also going to reflect on the report and the findings that were shared this morning.
Good morning, ladies and gentlemen. Good morning. Thank you for the opportunity. Respectful maternity care is not only about clinical outcomes. It is also about how women experience childbirth. Across the world, trained birth companions are recognized as an important part of improving women's experiences and strengthening maternity care systems. While South Africa's healthcare system provides essential clinical care, many women still experience childbirth feeling unheard, unsupported, and alone. Birth companions exist to ensure that no woman has to go through that moment without continuous support, dignity, and reassurance. My name is Gefilwe Sibenya, and I'm a certified birth companion, and I'm a representative of Doulas of South Africa, also known as DOSA. A doula is a trained birth companion who provides continuous, non-clinical support during pregnancy, labor, and the postpartum period. This includes emotional reassurance, comfort measures, guidance, and helping women communicate their needs with healthcare providers. It is important to emphasize that doulas do not perform medical or clinical tasks. We complement the healthcare teams by providing continuous presence and supporting women during this important moment. Research, according to the Cochrane Review on Continuous Labor Support, shows that women who receive support from a birth companion often experience shorter labor, greater satisfaction with their care, and improved birth outcomes. The World Health Organization recommends that every woman should have a companion of choice. Yet in many healthcare facilities here in South Africa, women still go through labor without continuous support, and access to trained birth companions still remains inconsistent across the country. This is where Julius of South Africa plays a role. As DOSA, we represent trained birth companions from multiple training organizations across the country, and we work to bridge the gap between communities and maternal health care services. Over the years, DOSA has made several requests for access to public healthcare facilities, but access has been inconsistent and processes unclear. In some facilities, birth companions are still perceived as untrained or disruptive. Over the years, DOSA has made several requests to access these public health facilities. However, there has also been progress in the Western Cape, where the Department of Health and Wellness Chief of Operations announced that Judas are welcomed and encouraged to support birthing women in the public sector through successful donor and NGO-funded Judah programs. This demonstrates the structured integration that structured integration is achievable. South Africa has local examples through the Limpopo Department of Health Birth Companion case studies, which demonstrates that structured birth companion programs can be implemented within the public health facilities. These examples show that integration is possible when there are clear guidelines and collaboration between health systems and trained birth companions. A standardized birth companion access model developed in partnership with DOSA is therefore essential to ensure that equitable support for birthing women across South Africa is available. In Gauteng, we have proposed the development of a memorandum of understanding between Julius of South Africa and the Provincial Department of Health to support a structured birth companion volunteer program at provincial and district level. This program would enable the responsible integration of trained birth companions into public healthcare facilities, ensuring accountability, clear guidelines, and alignment with existing respectful maternity care policies. We will do this through proper vetting, orientation, and registration processes. DOSA is committed to addressing concerns around safety, confidentiality, and collaboration with the healthcare teams. Evidence from many health systems show that birth companions can reduce pressure on healthcare rather than increase it by providing emotional and practical support to laboring women. Beyond access requests, Prof, DOSA advocates for meaningful inclusion of Judas in respectful maternity care action plans, as our role is already recognized within these guidelines. Integrating trained birth companions into maternity care strengthens compassionate care, it improves women's satisfaction with their birth experiences, and contributes to awareness of and about obstetric violence during labor and birth. Expanding access must also include community-based Judah programs endorsed by government and led by women at grassroots level who understand the cultural, social, and linguistic realities within their communities. South Africa has a proud history of community-based support, and community doulas represent a continuation of that legacy, women supporting women. The Embrace Movement for Mothers, the prevalence survey exploring women's birth experiences in Gauteng and KwaZulu-Natal provides a very important opportunity to reflect on what women truly experience within our maternity care system. We welcome the opportunity to continue engaging as trained birth companions in discussions on how South Africa can move from policy to implementation when it comes to respectful maternity care. Having certified birth companions present in these conversations, it is essential to ensure that policies reflect lived experience, cultural context, linguistic realities, and evidence-based practice. Finally, we propose the development of a national birth companion education and awareness campaign supported by all stakeholders currently represented here today. This campaign will ensure that women, families, and healthcare providers clearly understand the role and value of birth companions. Educational materials within maternity facilities, orientation for pregnant women and their companions, and community engagement between the maternity services and families could strengthen awareness and accountability within the system. Birth companions are not a disruption to care. Birth companions are not a disruption to care. Birth companions are not a disruption to care. We are partners in creating a safe, respectful birth experience for women and families and healthcare providers. The question before us is no longer about whether birth companions are valuable, but how we work together to ensure that every woman in South Africa has equitable access to respectful, supported, and dignified care during childbirth. Thank you.
Thanks, Kapilu. On a personal note, not related, but my sister's going to give birth in April, and I'm a birth companion. So it's really interesting to hear that reflection. Next up, we're going to call out Kulufelo Mpashele from Section 27 to share her reflections for about 5 minutes.
No, not at all. I'll be okay.
Okay, you get 5 minutes.
And 30 seconds.
And 30 seconds.
Cool. Thank you.
I thought it was around saying 2 different devices.
Yeah. Morning, everyone.
Good morning.
My name is Kolo from Section 27. And I'd like to thank, first of all, the Embrace team for the invite to come and get the report and read it. The results are shocking, they're heartbreaking. You don't know whether to cry or to get out of the chair or to be completely shocked. So, health is an essential element of human rights. If you think of Section 27, it says that everyone has access to healthcare services. But in that, you need healthcare services that are dignified, that are equitable, that are quality filled, and that gives you a sense of pride and relief that I actually got good services. Having said that, when you walk into a facility and you're not being assisted, it's a direct violation of your human rights. It goes beyond the medical that we're talking about today. It goes to what we are celebrating this year in South Africa, which is 30 years of the Constitution. The findings we heard today are deeply troubling. If 60% of people who give birth in Gauteng and KwaZulu-Natal over the past decade experience obstetric violence, then we really need to be concerned. But the numbers alone cannot capture what is happening or what it means in practice. One respondent who really hurt my heart when I was reading the story was that she says that I really got scared when the nurse hit me in my face and shouted at me. I was afraid to ask what's happening or what is wrong. Even though I wanted more children, I won't have any because of the treatment I received. How diabolical is it that a woman has to make a decision to sterilize herself to say that I don't want any more children? At Section 27, our work is grounded in the Constitution and the promise that it makes to everyone in our country. Section 27 of the Constitution guarantees the right to access healthcare services, but this right is more than entering a facility or giving birth when you're in a hospital. Access to healthcare means safety, respect, consistency, dignity. The experiences documented in this report of women being shouted at, ignored while in labor, denied medication, or subjected to procedures without their consent clearly violates their constitutional rights and beyond that of medical ethics. The fundamental rights of body integrity, equity, and dignity, as well as informed consent, were clearly not adhered to. This report is a reminder that when there is violence, it's simply not about the individual misconduct. It reflects deep structural problems in the healthcare system. It reflects nurses that are overworked, infrastructure shortages, resource constraints, and a hierarchy of models that has long been outdated. It contributes to an environment where disrespect and abuse can clearly be done. So what does this mean? It means that beyond changing the rights, it means that we need to change the system. First, we agree with the report that there needs to be respectful maternity care. The full implementation of the guidelines, as said by the Department of Health, is very critical here. These inform dignity, autonomy, informed consent, and the right to help to birthing companions. But implementation requires also staffing, infrastructure, and resources. So it's two sides of the same coin, but the same coin needs to work together. Secondly, we do agree that public participation is key and that patients need to be brought forward their complaints. But that can only be done if they know that they have the right to do that, or which is not being done. I must respectfully go against the Department of Health and say that you're not only a participant in public education and participation, it's the department that has to lead the participation and education. Again, if we are to change, then we are to involve everybody. Nurses, doulas, midwives, everybody's a part of this chain. We need stronger accountability mechanisms and to strengthen the Office of the Ombudsman and the Health Standards of South Africa. We must empower women in communities. And finally, the department has to improve its own data collection because Embrace has already done it for them. For organizations, for civil society, this report is an important vessel in evidence, in advocacy, policy engagement, and accountability. We have an important role to play as civil society in ensuring not only by the Embrace report, but by the department adhered to. This report asks a very important question. What does it really mean when we say that Section 27 of the Constitution is to be realized? If a woman can enter a hospital but is ignored, humiliated, or subjected to procedures without her consent, then the promise of dignity clearly falls flat. We believe that the Constitution requires more than access to services. It requires humanity, autonomy, dignity. The stories in this report should not end as this report as we are gathered here. It should not end as statistics that we all came gathered on the 11th of March at BIS and that's it. It should go beyond that. This is a catalyst for accountability, reform, and change. No one in this country, especially women, should be afraid to go into a hospital during pregnancy or childbirth. We all deserve dignity. Thank you. My last 30 seconds.
You're very good.
Thank you so much.
I really like your words around how this can be a catalyst for reform and change. I think that really strikes a chord, particularly when there's so much consensus in the room around what the challenge is. And I think that's very unique because often you find disagreement on whether or not there is a problem, but everybody who's reflecting on this is saying, we acknowledge that there's a problem, what do we do about it now? I'd like to call up Stembile Zola from Grow Great.
Thank you so much, Lindsay. Good morning.
Good morning.
Sure, I'm Zola from Grow Great, as mentioned. What a sobering truth that has been shared with us this morning, colleagues. And I believe this is helping us to be more intentional about our thinking and how we implement what we are implementing. 2 provinces have been shared about this morning. And I'm asking myself, what are the realities of the rest of the country? If so much has been shared for just 2 provinces, what is the reality in the provinces where we've not heard anything about? I'm from Grow Great, an organization whose vision is to halve stunting by 2030. Stunting, we believe, is a very serious condition that is as a result of prolonged malnutrition. And it affects the physical and cognitive development of every child, thus making children to be too short for their age and later robbing them an opportunity to learn and thrive. Sadly, 1 in 4 children under the age of 5 are stunted in South Africa. And that is precisely why we as Grow Great focus in the first 1,000 days of a child's life, thus ensuring that every child is given a great start in their life. To think that this challenge begins only when once a baby is born is a bleeding state. Hence, we as Grow Great have programs that precisely deal with these types of issues. I'll speak about the Flourish program quickly, which is a network of mom and baby classes, antenatal and postnatal, that are designed to support pregnant women and new mothers by providing them with essential knowledge, skills, to be able to navigate their way through motherhood in a confident way. So the program covers topics like general health, nutrition, pregnancy care, breastfeeding, bonding, and maternal health care and well-being, as well as the love, play, and talk and read components of child growth. It's a flexible, interactive program that creates a safe space for women to share experiences that they go through their, the rest of their pregnancy life and beyond that. A sisterhood where women feel free to be in one another's company to share similar experiences. And these conversations are private and confidential, respected in that regard. A lot can happen in the first 1,000 days of a child's life, sometimes good and sometimes bad. And sometimes, while we can eventually be able to change the status of a child's physical growth, the reality is that the brain development could have been damaged far more than we can be able to reverse. And that's something that we need to be very conscious about. Our program offers practical support, it gives guidance and knowledge to help women to be able to achieve great health, well-being, and stability. So obstetric violence is a serious problem for us. And it's definitely not acceptable because its effects are quite severe. It leads to physical, emotional, and psychological harm, which could in turn affect the baby that's being carried, that precious cargo that's being carried into the world. It also leads into increased anxiety and fear of childbirth. These are the realities that we are faced with. Trauma and PTSD symptoms. And you find a mom having given birth to a baby that they actually deny they've given birth to because of the trauma that they've experienced, and further mistreat the baby because of what they have experienced themselves. Decreased satisfaction with healthcare services, which then means no mom would want to come to access clinical services, which is what we are encouraging them to do in this mom and baby classes. Negative impact on breastfeeding and bonding with the baby. We are crying so heavily about moms feeding their baby the right nutrition, and nutrition that is good for not only their physical development, but their cognitive development. Breastfeeding, exclusive breastfeeding, is something we advocate for so strongly. But because of obstetric violence, we find that sometimes moms will be negative towards breastfeeding their babies. And then they don't bond with the baby because of some of these effects or these experiences that they face in these institutions. Abused women may care less for themselves. They may neglect themselves, and that affects the way in which they care for the baby, in the way they nurture the baby that they've brought into this world. Even before giving birth, they could just neglect themselves. So things like fetal syndrome also emanate from the type of abuse that they experience. Very important. Not only does this undermine the work that we do, but it renders our work frivolous and make it a challenge for us to be able to see the efforts or the impact of the efforts we put out there. And it further exacerbates the already heavy mother load that these women are experiencing on a daily basis. I mean, I've been cooking, cleaning, carrying the baby, we address respectful birthing in our classes, and we promote a respectful maternal care very precisely because we want moms to not be fearful or scared of coming to clinical or rather accessing clinical service. So this survey gave us a good insight that show us the blind spots that we need to target and deal with. The National Department of Health guidelines have got to be implemented collaboratively. This is not something that only DOH needs to do by themselves. We all need to put our efforts together to make sure that this works as best as possible. On our end, we will continue to strengthen our programs for better intentional support to the pregnant women and new mommies. And I'm actually glad that the Laundry Day became the continuation of the open voices, echoing the end of these injustices. And we would definitely support this movement. We have hope that when mothers are cared for very well, then they will birth children who will live well and thrive. We fully support this movement, we continue to empower and embrace women. So we say a big no to obstetric violence in South Africa, a very big yes to respectful maternal care, and a very big yes to a stunting-free nation where children grow great and flourish as the champions they are. Thank you.
Thanks for connecting the dots, Cindy. I think the work that's being shared here and what happens later on in a child's life and also in a mother's journey. Next up, I'd like to call up Uzinhle Chuku from Amandla.Mobi.
Good morning. Yeah, it's still morning. I'm from Amandla.Mobi, and if you don't know what we do, I'll tell you just now. We amplify the voices of the most impacted by injustice through scaling movement, building, and campaigning. We hold the powerful accountable and improve the lives of those who are impacted by that injustice. And I think as I was reading the reports, what kept on coming to my mind is that these are our members. We have members who take action, they sign campaigns, and we go on the streets with them, we mobilize them, and we go on the streets for various issues. And we're talking about people who are grant earners. We're talking about people who could never, any day, afford to go to a private health hospital. And that's most of South Africa, actually, if you think about it. And I know that we have this way, we've centered the nurse, we've centered the people the healthcare professionals who provide the service, but that's not who we should center. We should center the decision makers. We should hold the decision makers accountable. We should mobilize, and most of our campaigns show that when we get together and we have people power and we come over an issue and we hold the decision makers accountable, they have to shift, they have to listen to us. So I'll be sending you emails telling you to join us, telling you to sign our campaigns. Nonkululeko and I are already talking. I was so glad when I heard someone saying that that's a low-hanging fruit, and I saw that, okay, there is a low-hanging fruit. People are talking my language. This one of not allowing a deadly companion to do so. Why is that not the case? We are going to go to some department somewhere, whoever is the decision maker, we are going to go there and make noise. We are going to go there and tell them, and after we've heard also what our members are saying, I'm sure it's no different from what is being said. And actually, I'm thinking it's even worse. We have to know, I was thinking, even though I was reading, if I saw someone at work, or if I did anything that was rude to my members, I'm telling you, if I'm not signing a warning by the end of that day or something, why is it that you have institutions where there can be a culture of people swearing at people? And I was so glad to meet someone, to hear someone from Section 27, because we had a fellow who's with them now, who wrote a petition about someone in a local clinic in the East, where there was a nurse who was constantly swearing at foreigners, where there was a nurse, and it took so long to fire that nurse. So it means there's something also about how these institutions are managed, and if we don't get up and mobilize around those issues to make sure that our health institutions are running in such a way that respects women, that gives us dignity when we go there. We have to do something, and we have to compare. We can't just stop at saying, oh, this is a problem and leave it there. We have to do something about the problem. We have to take an action around it. So already, please join us, because I know we are going to go somewhere. We are going to make a noise somewhere. We are going to call out people who are responsible. When you're monitoring, it doesn't help to have these beautiful policies, these beautiful guidelines, if you cannot enforce them. Where's your monitoring? Where's your evaluation? What happened? How come is it there are no warnings that are given to people who do that within your workspaces? So we can't ask it, we can't petition with complaints. We have to go take it and we have to enforce it. So with that, with those words, I say, Amanda, when I send you an email and say, come to this.
We'll be awaiting those emails. Next up, I'd like to call up Mpho Gwawana, who is from the Women Affected by Mining United in Action.
Thank you. The people looking to serve. Serve, yes.